Hi there, this is Deborah from Empowered to Birth, and welcome to your pre-reading or pre-watching package to your VBAC Master-Class. So you're going to be attending the VBAC Master-Class with me at some stage in the near future, and we're going to talk about the top 10 tips for a successful VBAC. But to prepare you for that, it's really a good idea to have some of the statistics and the guidelines out of the way first so that you've got a deeper understanding when we come to those top 10 tips. So what I'm going to present to you in this short video is the policies and the procedures and the protocols that have been written down by the Royal Women's Hospital in Melbourne, which is our go-to resource for the best practice guidelines in Victoria. So I'm going to share the PowerPoint with you, and then I shall talk you through what all those statistics mean. So the Royal Women's Hospital in Melbourne are the go-to resources for statistics about everything to do with birth. And in this case, we're going to be looking at their vaginal birth after cesarean statistics. So this chapter is taken from the policy guidelines and the procedure manual of the Royal Women's Hospital in Melbourne. And a vaginal birth after a cesarean, we can only truly say it's been a successful vaginal birth after the process. I don't actually like to prefer to refer to it during pregnancy as the next birth after a cesarean. So whether that birth ends up being a cesarean or a vaginal birth, it's still a successful birth. But for the sake of this presentation, we will refer to it as a VBAC. So to have a successful vaginal birth after a Caesar, the range of statistics is from somewhere between 55 to 85%. And the predictors for success include if you'd had one previous vaginal birth and a caesarean before this current pregnancy and birth. If this labour starts spontaneously, it increases the chances of the baby being born vaginally. When you arrive at hospital, if your dilation is more than 4 centimetres, it's a predictor for success. Another predictor is if a previous caesarean was due to that particular baby being malpresented, as in if its head wasn't completely lined up for optimal birth in the pelvis. So it had its head a little bit asynclitic or a little bit off to the side. Also, if the previous birth was because of a non-reassuring CTG, or the baby's heart rate trace wasn't showing reassuring features and it required a caesarean birth for that baby's reason. If there's been at least 18 months between the two births or the previous caesarean birth, and if mother's BMI or body mass index is less than 30, if the baby's birth weight is less than 4 kilos, and interestingly enough, the Women's Hospital say that having an epidural for labour increases the chance of a successful vaginal birth. Being Caucasian, under 40 years of age, taller than 150 centimetres, and also having a female baby. More predictors for success, and this is looking at the reasons for the previous caesarean. So if the previous caesarean was for breech, or that baby had its bottom down and its head up, 76% success rate. Fetal distress, as in the previous baby during labour showed signs of not coping with labour. There again, 76% success rate. Slow progress, 50 to 60% success rate this time round, or CPD, or cephalopelvic disproportion. So the way the baby's head was lined up in the mother's pelvis was disproportionate and the baby wasn't going to fit in and through the pelvis. There again, 50 to 60% success rate. The lowest indicator for success is if mum got to fully dilated and an instrumental birth was attempted, that is a forceps or a vacuum, and that was unsuccessful, and that was the reason for a caesarean. So the success rate is down to 14% for that. The Women's Hospital recommend that there are a few contraindications for a vaginal birth after 2 or more previous caesarean sections. or if the previous caesarean was what we call a classical caesarean. Now, most days in the third trimester of pregnancy, women would be having a caesarean. It would be referred to as LUSCS, L-U-S-C-S, lower uterine segment caesarean section. So in the third trimester of pregnancy, the lower segment opens up. It's not there in the second trimester of pregnancy, and the incision is vertical across the lower segment. If a previous caesarean had been in the second trimester before that lower segment had developed, it would be upright or a T shape or a J shape. And that means part of that incision is vertical rather than horizontal, and that is not compatible with the uterus contracting safely to have a vaginal birth into the future. If the uterus had had a previous uterine rupture, it is not recommended to go through a labour again, as in if there has been surgery on the uterus that had gone into the muscle layer of the uterus, that's the myomectomy. Or if there was a medical or obstetric reason that had been written in your file that is not recommended for a repeat caesarean. Now this section is going to go through the statistics for the mother and for the baby, for the risks and the benefits of a vaginal birth, a repeat caesarean, or an emergency caesarean. So bear with me as we go through these. These are rather dry. So the risks to the mother of having a vaginal birth are 0.5% chance of having that previous scar rupture. And if you look at the flip side of that, that's 99.5% chance that that will not happen. And that often is the biggest fear that is put to women, that the uterus might rupture. Well, you think of the statistics and there's 99.5% chance that it won't happen. There is a 24 to 28% chance of requiring an emergency caesarean. There again, that's about a 75% chance that it won't happen. There's a 10 to 15% chance of an instrumental birth, and there is the same statistics for perineal damage, whether it be a vaginal birth after a Caesar or just a regular vaginal birth. 1.7% chance of needing a blood transfusion and 2.9% chance of endometriosis developing as a result. Now, the benefits to the mother of having a vaginal birth are there is 72 to 76% chance of being successful in birthing the baby vaginally. There's a shorter hospital stay. There's an increased chance that future pregnancies will be birthed vaginally. As in, if you've had one Caesar and a successful VBAC this time, then the third pregnancy, you've only got one past Caesar and you're more likely to be successful in having another vaginal birth. Whereas if you've had one previous Caesar, this birth is either a repeat or an emergency Caesar, then the future pregnancy would automatically be put in the category of you would require a third Caesar, not attempting a vaginal birth after 2 previous caesareans. If you have a vaginal birth, you're much more likely to have immediate skin-to-skin contact with the baby at birth, and that increases the chance of successful breastfeeding at the 3-month mark. So for the baby, for a vaginal birth, the risks and the benefits. So the risk of labouring and vaginal birthing is there's a 0.1% risk of stillbirth after 39 weeks, 99.9% chance there won't be a stillbirth, 0.04% risk of perinatal death related to the labour, that's 99.96% chance there will not be any adverse outcomes, and 0.08% risk of HIE, which is hypoxic ischemic encephalopathy, so a transient lack of oxygen supply to the brain, which can lead to brain damage. So 99.98% chance that will not happen. So those statistics are very, very slim. So the benefits to the baby of being born vaginally, there is only a 1% chance of having respiratory problems. And according to the Women's Hospital, they were the only statistics that they put forward as being a benefit to the baby. Now, I have added but there are a few more benefits, in my opinion. That when labour is started by mum's natural hormones, and the natural hormones drive labour, baby is much more prepared to initiate their first breath at life. Their transition to birth is much more hormonally driven. When they're born vaginally, they're coming into contact with the bacteria in the birth canal and around the anal area of the mother, so it's going to be more likely to seed their microbiome and have a healthy gut flora. Also, that immediate skin-to-skin contact is a benefit to the baby, and the greater breastfeeding statistics are also a very strong benefit to the baby as well. Now, to the mother, the risk versus benefits of having a planned elective repeat caesarean, and that would be planned for 39th week of pregnancy. So the risk of having a repeat caesarean, 0.1 to 0.2% chance of having serious surgical complications. So that's a 99.8 or 99.9% chance of not having surgical complications. But it also, having a repeat caesarean, increases the risk of placenta previa or placenta accreta. Now, placenta previa is what is the way it's described as having the placenta over the cervix, over the opening to the uterus. So in future pregnancies, the cervix would be covered by the placenta, and that's what that's saying. Now, placenta accreta is where the placenta is growing not only on the lining of the uterus, but it's actually growing into the lining of the uterus, and that increases the chance of a woman needing a hysterectomy at the time of birth. There is also one of the negatives to mum of having a repeat elective Caesar is a longer hospital stay. The benefits to mum of having a repeat Caesar, she knows the date for the birth. There's only a 1% chance of requiring a blood transfusion. There's a lower chance of endometritis. So that is an infection in the lining of the uterus. That's 1.8%. There's no risk of a uterus rupture because she is not labouring. She's having a repeat Caesar. And there's no risk of any vaginal tearing because the baby is not coming out vaginally. It is coming out through a surgical incision into her abdomen. And they also state here that one of the other benefits is that mum can have a tubal ligation or be permanently surgically sterilised at the same time as birth. Now, to the baby, the risks and the benefits of having a repeat elective caesarean. There's a 1 to 3% chance of having respiratory problems if the baby's born at 39 weeks. If the baby's born at 38 weeks, that chance increases to about 6% of having respiratory problems. And that is one of the reasons why it's offered to mums to have steroids to increase the surfactant in the lungs so that when they are born by a caesarean section without having had a labour beforehand, that their lungs are a little more primed to take that first breath at birth. So the benefits to the baby of having a repeat caesarean is it decreases the chance of stillbirth at the 39th week mark, and it avoids the chance of having that HIE, the hypoxic, ischemic encephalopathy, so lack of oxygen to the brain at birth. And as you remember, those stats were something like 0.02%. Now, the risks of having an emergency Caesar following a trial of labour after a previous caesarean. So that is not having a planned elective Caesar, but having a labour and then having a caesarean birth. So the chance of that uterus scar rupturing increased from 0.1% to 2.3% if mum has gone into labour and then has a caesarean birth. Uterine dehiscence, so that is the scar has started to open. So it increases from 0.1% to 2.1%. Requiring a hysterectomy at the time of birth for a planned elective Caesar, the chance of a hysterectomy is 0.1% and it increases to 0.5% for an emergency Caesar. Blood transfusion increases having a labour and then a caesarean, from 1.2 to 3.2%, an endometritis, so that is inflammation or an infection in the lining of the uterus, 1.2% chance increases to 7.7% chance if mum has laboured before an emergency caesarean. Having a repeat caesarean puts future fertility at risk. So having one caesarean, there is a fourfold risk of placenta previa, but and that, as we said, placenta previa is where the placenta is low-lying and it is over the cervix. So every caesarean after the first increases the chance of that happening from 0.2 to 0.3 to 0.5, nearly 0.6 to 2.3 to 6.7% chance of that placenta previa occurring. The risk of hysterectomy for each subsequent caesarean goes from 0.6 to, it drops with the second, but then starts to increase again to 0.9, 2.4, 3.4 to nearly 9% requiring a hysterectomy at the time of caesarean birth. Now, induction of labour is bringing the labour on from not even having started labouring, and augmentation is doing something to speed up the labour when labour has started but is not going quickly enough according to what the medical professionals would like. So maybe artificially breaking a bag of water around the baby, or putting up the synthetic oxytocin to increase the strength of the contractions. So there is a 2 to 3-fold increase in the chance of uterus rupturing when induction or augmentation of labour occur. The risk of having a caesarean increases from 1 to 5 times when the labour is induced or augmented. And an induction or an augmentation of labour when a woman has a previous scar on her uterus should only be considered when there is a senior obstetrician involved and is on site at all times, and when women are unclear on the risks associated with artificially getting her labour started. So thank you for listening to the statistics that the Royal Women's Hospital put out around their policies and procedures for a vaginal birth after a caesarean. And while this topic is a little dull and a little dry, I am happy to get this out of the way over this video format. So when we get together at our VBAC Masterclass, we can talk about all the gutsy, really juicy topics of how to make those statistics work in your favour, and what are the things that you can put in place to make that vaginal birth after a previous caesarean much more successful. So I look forward to seeing you at our VBAC Masterclass. And if you are not booked in for a VBAC Masterclass and you would like to, please give me a call. My details are on Facebook and on Instagram and on my webpage at Empowered to Birth. So thank you very much for listening. Bye.